And none of that is useful. What's useful is really to understand that the patient is in charge of his or her recovery, that we can be witnesses and allies and helpers, and we have a lot of professional skills and knowledge to bring to this task. But it's the patient's life, and we can't control it. We can't compensate for what was done. We can only help with the recovery process, which, you know, is a very painful, long struggle that requires a lot of courage and motivation and grit and determination on the part of the patient, and
dedication on the part of the psychologist.
Yes, but we can only bring as much dedication as the patient has.
Sure.
We can't bring more.
No.
And
So
we can find that the patients are often, if we put it to the patient that way, they're very willing to cooperate and to be in charge. I mean, it's good news and bad news to the patient that the patient is in charge of recovery. It means we're not going to dominate the patient, we're not going to control the patient, but we're also not going to rescue the patient.
Yeah, but still, they sometimes reenact in this way, and they put you somehow, you're induced, or how you say, to become
you feel
the one who is responsible for the treatment, who's responsible for the cure, and you do it and you don't do anything.
And you're not doing it
I'm
right,
not getting better.
Right,
so
right.
what the hell are you doing?
Well, at those, and by the way, because I'm not in practice anymore. I only supervise. So I teach, every year I supervise a number of trainees who come to our program who feel, so terribly disempowered by just that stance of the patient. Sure. And as relative beginners, they also feel, I'm not good enough, I don't know enough, I'm not doing this right, and then they come to me sort of wanting the right answer, and I'm always telling them to go back to the patient, that the person who has the right answer is the patient, and that you can share your dilemma with the patient. If you feel stuck, you can say to the patient, I'm feeling at an impasse here because on the one hand you seem to want this, but on the other hand you want that. So you put the conflict back to the patient where it belongs, and then how can we solve this problem together? You're offering.
But that's essentially a psychodynamic point of view.
Oh, of course. Yeah.
Could you say something more about this? Of course, because that's not so natural for many people.
Well, for complex PTSD at the moment, and certainly for the severe end of the trauma spectrum, if you will, the anything beyond a very simple single impact trauma that was nobody's fault, and certainly when you're getting into multiple traumas, it's a long-term treatment. It's a psychodynamic treatment that this is I think the treatment of choice. We have maybe in the future we'll have a much shorter and more simplistic kind of treatment that will be effective. I tend to doubt it, but who knows what the future will bring. But at the moment, the state of the development of the trauma field is very primitive. We're hobbled by, the fact that psychology and psychiatry are riven by schools of thought that don't collaborate. And it's played out even worse in the trauma field because of the trauma dynamics that get replayed on a systemic level. So our knowledge is primitive, but what we do know is that it's a long-term recovery, and that the primary damage is to the self and to the self in relation, if you will, to the relational capacities and self-concept and self-integration and of the person. And those are not short-term treatments. Those are long-term treatments.
And what's your view on, for example, EMDR?
Well, it's a nice adjunctive treatment for, the EMDR people will say for complex PTSD, it's not going to be the be-all and end-all of treatment. It's going to be, an adjunct to what you already know as a well-trained dynamic therapist. If you ask somebody like Marilyn Cloytra, who has a very nice 16-week staged treatment model coming out of the cognitive behavioral school for complex PTSD, what she'll say is, and I hope I'm not giving away trade secrets here, but she said it in public actually at Grand Rounds, so I think I can share it, that she chose 16 weeks because she thought that was the longest treatment model that she could get through an NIMH review committee, and I think she was right. They being very, very heavily controlled by cognitive behavioral models of, that's who's on the review committee is. So, and it's a very nice treatment model. She has wonderful outcome data, but she says that in real life, if she uses the model, she uses multiple modules. People will do the stabilization module as many times as they need before they're stabilized, and then they'll do the more exposure module at their own pace, Thinking of PTSD as an anxiety disorder, which most of the evidence-based work, with the exception of EMDR, because they have plenty of evidence base for their work, but most of the cognitive behavioral stuff is about sort of the idea that this is a fear that needs to be deconditioned, and by allowing the person to revisit the trauma in a safe environment and allow the fear to peak and then subside, rather than to go to its natural. Marty Horowitz thought of this years ago as the way trauma should be treated, and it's. I think of that as necessary but not sufficient, because trauma is so much more than an anxiety disorder. It's a relational disorder. It's a shame. I'm thinking of it now as a shame disorder. It's a dissociative disorder.
It's a disorder of disconnection.
It's a disorder of disempowerment and disconnection. Okay. So maybe that's a good place to stop.
That's right, yeah.